Thrilled to see some of my northern colleagues in the participant list. So hi everybody, I'm Brianne. And I'm really passionate about learning health systems, so I was so privileged to be able to present today. So I do want to acknowledge I am calling in today from Thunder Bay, the traditional unceded territory of the Robinson Superior Treaty, signatory 1850. I work with Northern Ontario health teams, and I'll dig into what does that even mean. That there are many, but I think that this is really important for reasons that Walter acknowledged at the beginning of the presentation. But place is so important to our context and to what populations and communities need, and particularly acknowledging and also working towards self-determination of First Nations communities in the region. So 6 treaty areas across 90% of Ontario's landmass. Certainly reconciliation is a practice, it is dynamic, and where it's really relevant for learning health systems is acknowledging, recognizing, and working together when knowledge systems work and look differently. And that's really important from an evaluation perspective too. And I am by no means an expert in it. And I can point you in amazing leaders in this area if you would like to learn more about Indigenous evaluation as well. In the next 10 to 15, I'm hoping to give you a little bit of background why learning health systems evaluation looks differently, feels different in northern, rural, and isolated settings. As noted, we are unique. I'll give you 2, I'm not going to use the phrase case studies because I guess it is case studies, but 2 examples of basically ongoing challenges and potential solutions that we've had to some of those challenges, specifically related to evaluation. And then I'll wrap up with what have been my learnings, and maybe some of the other teams can reflect on, whether these relate to your experiences too. Again, some of you may have seen me present before. I really come back to this slide, but it's really great because someone asked very early on why evaluation, and both Catherine and Raham actually addressed it specifically in their presentations. But the Northern Health Equity Strategy, published in 2017, along with the report by Health Quality Ontario, showed that there are pretty substantial differences in our traditional population health outcome indicators. So our life expectancy is lower, variable west to east. We have higher rates of hospitalizations for most conditions, emerge visits for most conditions, person years life lost. So, for the epidemiologist and evaluation people, our pop health indicators do look worse among commonly measured outcome indicators. And so this health equity strategy was great because it came out with specific recommendations about how we can begin to address this with a collective and northern specific approach. And I'm here to tell you, 7 years later after publication, all of those recommendations are still true today. And again, specific to evaluation. Now, this was more pointed towards some of the hospitals, but hospitals play a huge role in our Ontario health teams in Northern Ontario, that there is no dedicated healthcare strategy. So flagging, we need to consider the Northern context as a reason to specifically plan, implement, and evaluate programs for Northern populations, communities, and health systems. And in particular, big underscored, emphasized statement, programs for patients and healthcare staff in Northern Ontario are not regularly evaluated. Okay. So there's rationale for my work and for a lot of the work that people on the OHTs are doing right now. A little bit about what the Northern Ontario context is, and again, a lot of uniquenesses, and I think many of you will find some commonalities with your own experiences and contexts. So we have 11 Ontario health teams. I screenshotted Inspire's website to give you a little bit of a sense of where they are, where the service providers are, although that we have some challenges with as well. We do have 3 in the initial 12. Primary care is often the only care. And I actually, again, screenshotted this picture from a 2011 ICES report. And so those little red dots that you see, people living in those communities have to travel over 60 minutes to see a primary care provider. So it's a little bit more challenging even for hospitals and emerge departments. So just so you know that travel and I think, no, you can't really see the road system, but some of those people also have to fly to primary care providers. So sometimes it's the only care, and it might be delivered in unexpected places. So we collaborate. So this isn't all about all the gaps and disparities and inequities we face. You know, there are a lot of strengths that Northern populations, communities, health leaders demonstrate, and collaboration and connection to our communities is one of those strengths. And also, you know, I keep talking about Northern Ontario as though it's a singular entity, and really it's not. We are incredibly diverse. There are over 100 independent First Nations communities in Northern Ontario. There are heavily Francophone areas. We do have some more in our urban centers. There are higher immigrant populations, but just by the reality of being in the north, we are often thought of as a singular entity and other to perhaps the more mainstream Ontario population. What is unique about this context? Why is it important? And so I've included the Learning Health System Action Framework here too. And so we do have a smaller workforce. I think I noted a couple comments in the chat, and that leads to generalists. We have a lot of generalists. We hear that in clinicians a lot. We hear rural generalists because primary care providers often have to wear the hat of specialists. And so in the evaluation context, that means that our evaluation experts are also going to be, doing the QI, doing the reporting, being project managers. Perhaps they're clinicians, wearing so many different hats, and that has implications on the kind of work that we do and how we work together. And again, we collaborate because we need to, and we're good at it. So a lot of what I'm talking about is actually working between and across Ontario health teams. And our pop health profiles, our priorities, our needs are often different from, say, the provincial average or the provincially stated priorities. And so that's something that we have to balance. How do we move these provincial directions forward, or even regional priorities forward, when we have to also focus on what is most important to the populations who we serve? And I'm coming from Nausim University, but I work with some of the other academic institutions up here, other universities and colleges, and they explicitly identify that they want to be socially accountable. And so being accountable to Northern Ontario means providing value and the communities finding value in what they produce. And so there's the embedded, the value of an embedded evaluator or researcher. How does our health system context influence evaluation? I'm hearing this from perhaps non-Northern OHTs. Some OHTs might not have evaluation capacity on their team, or data or measurement, and so not only are there accountability implications there, just being able to do the reporting that needs to get done, but, to be able to do the really cool logic models like that we've seen in the previous two, we need to have the dedicated evaluation expertise at the table, which we've heard. This has to come from leadership, that this is important. And luckily, all of the OHTs realize this and are trying to strategically develop ways to build capacity and also provide capacity where it currently sits. And so, the example that I'm giving here is in the Northwest, although the Northeast is also working similarly, and they work across OHTs as well. In the Northwest, they're creating a structure to facilitate evaluation support and guidance for data-related efforts. And so this is, I'm pulling from Catherine's presentation, where it's aligning some of the need to do's like CQIPs different reporting to funders, as well as the actual things that matter, the evaluation pieces. And Reham made a good point about those. And so we have this regional working group for data measurement and evaluation, where there's a standing committee that brings together these different pieces of expertise, and it brings in some of the local people doing some of the work, or wearing one of the data measurement evaluation hats among their entire workload. And so we've got a big scope of work. So bringing together people, yes, we want to do evaluation for things like integrated clinical pathways, for things like, primary care networks, for example. I'm pulling from some of the accountability pieces. And that means determining metrics, producing logic models, coordinating data collection, et cetera, filling out those matrices that Walter showed in the beginning. We're pretty early. I'll tell you that we're pretty early right now, but we have noticed a few things. So this is really cool because we do have 2 I-12s in the Northwest and 2 non-I-12s, and so this alignment is allowing the 2 non to sort of stay in the loop and know what's going on and have that additional evaluation and data capacity. We are now able to do some data and evaluation things and plan them strategically in ways that didn't exist before. And also we're trying to build capacity so that it's not just staying within this group, but we can invite others, and we can make evaluation sexy to other members of the OHT, to their staff. And how do we build that capacity? And this is really helpful to align with what's going on with the digital transformation. And so that's really big from a data collection perspective. How do we align with some of the new data structures and infrastructure that's going in? From the hotspots or perhaps challenges, yeah, so there's a lot that this group is being asked to do, and it's really hard because, coming back to that other slide, we're wearing a lot of hats already. So how do we manage all of the evaluation asks, with a small group and attending different meetings, that sort of thing? So, which is my second point, all of the meetings, lots of meetings to go to. Because it's important to do things collectively. And also, how do we respect local priorities and wanting to do things a certain way and what's meaningful there with sort of the regional consensus? Those are things we're working through. The other piece is, so our health system looks different, but so do the populations, as I alluded to. As a result, we have to think about data differently. And again, both Catherine and Reham spoke to this as well, but I'm thinking of Catherine's slide with the black box. So what we're getting from the central resources, who are amazing, by the way, but I'm thinking of Inspire PHC, some of the reports, we often have the asterisks. Oh, don't, don't make too much of this. It's an incredibly volatile indicator. We have small sample sizes. So 90% of the landmass, 6% of the population of Ontario, and then across 11 OHTs, like pretty small. The way that people access healthcare looks different. So we don't trust OHIP billing that much. Emerge visits, actually, they're probably more common because that's where primary care providers, i.e., the providers in the community are choosing to see patients because they need to keep the ER open. How do we deal with this? Perhaps elephant in the room, not elephant in the room, Indigenous data and knowledge sovereignty. How do we honor this? Recognize First Nations, Inuit, Métis people's right to own, control, access, possess their data. But then how do we also do this in a way that we can do evaluation work in a way that acknowledges that our health systems are working with Indigenous populations too. And so I've done a shout out to Memo Ayamoin, which is a collaboration that works with ICES and Dr. Jen Walker to do some really amazing work there. And so what we're hoping to do, actually, that regional collaboration, as well as some of the teams in the Northeast who are great and enthusiastic too, is Northern Health Equity Strategy 2.0. So we're going to develop an equity-centered data strategy that allows the communities to own the data. And I'm using communities in a very sort of vague sense, and that's because we don't have clarity on what it will look like yet. Yes, we're hoping to move forward again super early in this, but it's going to allow us to answer those meaningful evaluation questions. Luckily, there's a lot of interest in this, in the OHTs, in other academic partners, other health system partners. Let's move it forward. As I said, it's going to allow us to see whether, whatever it is we're evaluating is actually doing things that we're intending for it to do. And Rayham spoke really nicely to that. And of course, it is a collective coordinated approach to advance some of the things that we're being told to advance, as well as the things that we want to advance. And so some of the hotspots, actually it was something that I say a lot, and I'm sure others on the call do. Sometimes we just have to accept the data as it comes. It's not perfect, but it's good enough. But sometimes it isn't good enough. Sometimes it's not. And so, yeah, I've made a little comment about the law of large numbers here. And how do we resource this? How do we just keep adding more hats to the people that we have? Team-based worked best. I've heard the others speak about that as well. Capacity building is part of the strategy. So we're trying to, democratize evaluation, but how do we make sure that others are involved and engaged and maybe eventually can independently help create those logic models or data collection strategies, without necessarily the support of the, whole team. Data collection is inevitable. Again, I've heard this now from both previous presenters. Walter alluded to it too, and know the so what ahead of time. And Rayham really spoke to this, and as does the learning health system action framework. Is once you have the data, you have to do something with it. So what are we going to do? And I think that that's really important too. So with that, thank you.